Good afternoon, everybody. Thanks for inviting me here. So today we're going to briefly discuss a multimodal approach to pain management in sickle cell disease, but this can be applicable to any pain syndrome. So what is a multimodal approach? What does it mean? So having a unidimensional approach limits outcome, and using one medication or mode of treatment may be inadequate to achieve optimal pain control. So the multimodal approach uses different classes of analgesics and various interventions, each with a different mechanism of action to optimize efficacy. The use of the multimodal approach in management of pain can have an additive and synergistic effect, and this results in improved pain control, reduced adverse events, and most importantly, increased patient satisfaction. So before we get there, but let's define pain. So what is pain? The American Pain Society definition of pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. The sensation of pain is always unpleasant and therefore an emotional experience, and there's varying degree of severity. It is subjective, therefore it's where and when the patient is telling us the pain. The perception of pain is shaped by the past experience of the patient, the current cognitive state of the patient, and their future expectations. So for example, if the patient had a poor experience with pain and pain control in the past, that will be a bias for them that will affect their perception of pain that's ongoing subsequent event. If they are depressed, anxious, that will also result in how they're perceiving the pain. If you know, there'll be more pain if you're feeling depressed and anxious. It will increase the anxiety, and the pain will the anxiety and the depression will increase the pain, and that subsequently add to the anxiety itself and become a cycle. Future expectations, if the patient's expectation is the pain will totally be controlled, there'll be a total zero, then it'll become more difficult to control and result in adequate pain control. The biology and perception of pain is complex and dynamic and involves various interrelated systems, therefore having a multimodal approach is beneficial. So what are the different types of pain syndromes? Okay, so we'll touch briefly on these. So there's nociceptive pain, and this is actually where there's signaling tissue damage or potential tissue damage is ongoing, involving tissues such as the muscle, bone, cartilage. This is an adaptive pain because it's telling you of something potentially bad that may be going on. There's stimuli such as a mechanical, such as a pinprick, or a thermal, like heat and cold. So that's the actual stimuli, and that would be examples of resulting in nociceptive pain. There's inflammatory pain. Again, this is an adaptive pain where there's pain hypersensitivity because of ongoing healing. This is reversible, and you know, there's the stimuli that happens, the damage happens, but then there's the secondary inflammation there. So for example, I bump my toe, and I feel the pain, that's the nociceptive pain, but then subsequent the swelling and inflammation, that is that's the inflammatory pain. So the throbbing pain that's subsequent to that, that's, for example, inflammatory pain. This other type of pain is functional pain, or actual dysfunctional pain. In this sort of pain, there's no actual anatomical damage, but there's actual peripheral sensitization, central sensitization, where there's perception of pain. Examples of this would be such as fibromyalgia or irritable bowel syndrome. And this is actually maladaptive and could be potentially chronic. Subsequently, there's neuropathic pain. Neuropathic pain is actually where there's the damage to the nerves themselves. There's no ongoing tissue damage, but there's nerve damage, and there's peripheral sensitization, central sensitization, and then the pain could be potentially, or more commonly, chronic. Examples of this kind of pain would be like diabetic neuropathy or postherpetic neuralgia. Those are types of neuropathic pain. And then there's mixed type of pain where there's different components ongoing at the same time. So with sickle cell pain, it's classically described as a nociceptive pain. There's vasoocclusion going on, there's ischemia, bone infarction, and that's classically been thought as a nociceptive pain. But most likely is a mixed type of pain. Okay, there's probably an inflammatory process going on. There's probably a neuropathic component and the nociceptive component. The sickle painful episodes can be persistent and unrelieved, which could result in neuroplasticity, okay, and therefore is potential for chronic pain state. Okay, there's peripheral sensitization, central sensitization, and subsequent neuroglial remodeling, and increased potentiation and subsequent chronic pain. Therefore, there's, with these acute painful episodes that sickle patients have, which may be frequently and uncontrolled, therefore may subsequently result in chronic pain. Therefore, acute painful episodes have a potential of becoming a chronic pain state. So essentially, acute pain begets chronic pain, potentially. So what are the pain treatment goals? Primary reason for using we can use like an 11-point scale, like 0 to 10, which we're familiar with. And this is a primary reason is to have a set treatment goal, okay? And evaluate the effectiveness of the treatment. We ask the patient, what's your pain? They'll rate it as 3 out of 10, 4 out of 10, and say, what would you like to be a 0? So that gives a solid idea of where you have to go. But then you concentrate on getting to that level and focusing on just reaching that, let's say, that 0, and that might at times be unrealistic and not achievable. Okay? So actually, I like to use the comfort function goal, which is defined as the highest pain level that can exist without interfering with the patient's ability to perform necessary desired activity. In other words, what's the pain level that is noticeable but not bothersome? Okay? I like to ask the patient, is your pain adequately controlled? If the pain is adequately controlled, the level is a 7, but the pain is adequately controlled, that's the pain control has been achieved, okay? And we'll concentrate less on the numbers. So to achieve that, we can use different modalities of pain treatment. They could be divided into pharmacological and non-pharmacological modalities. But then within those, there's different types, and we'll briefly touch on each one a little bit. For example, pharmacological, there's different analgesic medications such as opioids, non-steroidal anti-inflammatory drugs, and other adjuvant medications. In non-pharmacological, there's dietary supplements, physical medicine, cognitive and behavioral interventions. So discussing pharmacological, we'll start with opiates. Opiates refers to all analgesics that possess morphine-like properties. Examples of these are codeine, morphine, hydrocodone, oxycodone, hydromorphone, meperidine, and so on. These are the mainstay of therapy in acute painful episodes in sickle cell. They're used for moderate to severe pain, which is usually the acute painful episodes that the sickle patients are presenting with. And opiates relieve pain by blocking the delivery of this message of pain. They bind to the specific pain receptor sites in the central nervous system, spinal cord, and brain. The pain receptors which are blocked by opiates are called opiate receptors, and there's different types. There's mu, kappa, delta. Mu is the main one. And the different opiates affect different subgroups of these receptors, which explains their slightly different effects with different patients. So opiates, for consideration of what opiate to select and the route of administration, you have to take several things into consideration. The type of intensity of the pain you have to take into consideration. The analgesic history, what has been given to the patient in the past. What's the patient preference, okay? So this should not be ignored. What's worked for you in the past? You can ask the patient, and sometimes that may be ignored by the provider. And then also it's important, provider comfort with using that particular opiate or modality is taken into consideration. The routes of administration of opiates may be IV, intravenous, subcutaneous, intramuscular, transdermal, and oral. But when the sickle patients are presented with acute painful episodes to the hospital, pain medications are preferably given IV. We're assuming the patient took PO medicines at home, which didn't help. That's why they're here. There's no point for them to be here. Now we're putting them on PO medicines. So if we're unable to establish an IV access, we would subsequently give it subcutaneously and not intramuscularly. Intramuscularly has more erratic absorption, and giving repeated injections in the muscle can cause necrosis. Therefore, it's more preferable sub-Q if we can't get an IV established. But there are side effects from opiates. And these are the most important one that we worry about is respiratory depression. This is rare but serious, but subsequent when you're seeing sedation happening, that could be then leading to respiratory depression. So we try to be careful balancing how much opiates we're giving with the side effects, especially the sedation, okay? But by using the other modalities, analgesics, we can limit these side effects and potentially the most major one, respiratory depression. So other medications, analgesic medications, like we said, it's non-steroidal anti-inflammatory drugs, NSAIDs. And in sickle cell, there's most likely an inflammatory component also ongoing, as we said, with the ischemia and the infarction and so forth. So some few examples of NSAIDs that we can use is ibuprofen, naproxen, Toradol. Toradol we can actually give IV, and we use that as a synergistic for synergy, and we use it during painful episodes when the patient present. And NSAIDs work by blocking the production or release of chemicals that cause inflammation. They're used for mild to moderate pain. They do have a ceiling dose, meaning that if I go above a certain dose, it's not going to be helping with the pain, but then we'll have subsequent bad side effects. The benefits of NSAIDs is non-sedating, so I can add it on to the opiates, and it won't enhance the sedation that's involved. The downside is that, yes, NSAIDs may have renal effect and may cause stomach ulcers. Sickle cell patients, the sickle cell disease itself can affect the kidneys, therefore by adding NSAIDs there might be another insult, so we have to be careful adding that into the equation. Other medications that we can use, these subsequent ones will address a little bit with more of the neuropathic component. Antidepressants, examples such as amitriptyline, Prozac, Zoloft, but I'll just give one example, and the one I most commonly use is amitriptyline, and this helps the pain by enhancing the endogenous descending pain inhibitory system, and also it competes with morphine in binding the plasma protein, so if you're using it along with morphine, it might be more free morphine for binding for pain control. Doses that we use for pain control are different than those for depression. They're much smaller. For depression, doses are 100, 150 milligrams, but for pain control, we start very low, like 10 milligrams, and work our way up. Usually, I haven't seen more benefit by going over 50 milligrams for pain control. The downside is it won't work immediately. It'll take several weeks for that to take, for that to take effect. Usually, I've seen it as low as 7 days for pain control, but so it doesn't work immediately. So that's the downside. The other downside is also has a sedative effect. So adding on to the opiates may increase the sedation. So you have to be careful adding on. Also, it can cause urinary retention, orthostatic hypotension, and dry mouth. So if it's a more older patient, you have to be careful adding it on, and results in hypotension and falls. So starting at low dose and titrating up is how we do it. Actually also helps with sleep. So actually if the patient is having difficulty sleeping because of pain, adding this on would be actually a good agent. So other pain medicines or adjuvants that we can use for pain control, we can use anticonvulsants. Some examples of these are gabapentin, which is Neurontin, pregabalin, which is Lyrica. You've seen commercials on that on the TV for fibromyalgia, and then carbamazepine, which is Tegretol. But let's use gabapentin. This is the more common one that I use, and this modulates the cellular calcium influx into the nociceptive neuron itself. The thing is, there's no established dose for pain control. Therefore, I start at a low dose, like 100 milligrams 3 times a day. And again, it will not work immediately, so it takes a little bit of time, okay? Side effects, it does have sedation, and therefore adding on to opiates, we have to be careful but we can enhance the sedative effect. Local anesthetics, I've used two successfully. Example of this is transdermal lidocaine, and this decreases the neural excitability. Currently, the only thing that's approved for is for postherpetic neuralgia, but we use it off-label for neuropathic pain, and I've had success, as I said, in like some patients by using it, and it helps if it's for localized area. The only side effect, downside, is local irritation, so it could be pretty okay to use. Also, topical agents I've used, such as methyl salicylate, which is like Bengay, or capsaicin. Capsaicin, example, is a natural substance that occurs in hot chili peppers. It works by prolonging the deactivation of those nociceptors. I've had mixed results. 50% of the patients like it, 50% don't. I usually tell them to put it on the larger joints like shoulders, hips, again for localized pain. And the irritation because of like the hot chili might prevent them from using it consistently because you have to use it consistently for it to be effective. So the big downside is the local irritation and the patient compliance. We've also used NMDA antagonists. NMDA receptor, which is a glutamate receptor, it plays an important role in the hyperalgesia and chronic pain. Examples of medications for NMDA antagonists are methadone and ketamine and dextromethorphan, that's cough syrup. The one we commonly we've used often is ketamine, and when we use it concomitantly with opiates, it may significantly improve pain relief and the dose of opiates that's necessary for pain control. The ketamine is used for anesthesia, but in this case it's very low dose and as compared to the anesthetic dose. The side effects of it are hallucination, confusion, hypotension, and arrhythmia. The big one I've seen is hallucination and delirium, and that's why the patient can't really tolerate it. And the pain services helped us institute this here, and we've had good results with it, and now we're trying to implement a retrospective study to look and see how actually in those cases we use it has helped. So now we shift to non-pharmacological interventions, and again these are dietary, physical medicine, and cognitive behavioral interventions. And for dietary supplements, for sickle cell itself, there's no specific diet that we recommend. I recommend a healthy, rounded diet with adequate calories and micronutrients. Also recommend plenty of fluids, such as water or juice, to avoid dehydration, because when the patients become dehydrated, that increases risk of going into the painful episode. Ask them to drink plenty of fluids during physical activity and avoid caffeinated beverages. Other dietary supplements that may be beneficial in sickle cell or is beneficial are folic acid. Folic acid is an important nutrient to start for making new blood cells, so we recommend daily supplementation with that. Other vitamins that we've noticed sickle cell patients to be low in is vitamin D, and we also check that, and if necessary, we supplement. Other micronutrients, magnesium, zinc, and potentially omega-3 fatty acids have been shown to be helpful. So physical medicine, what is physical medicine? It may comprise of heat, physical therapy itself, exercise, massage therapy, acupuncture, electrical stimulation. So for heat, hot packs, we have here bear huggers, which are actually blankets of hot air that come in, is a blanket with hot air in it, and patients really like that. Physical therapy, usually if the patient's being in hospital for a few days, we recommend them moving up and moving around. That will help with, I think, so they don't become stiff and increase pain. Exercise recommended as what the patient can tolerate, and each patient prefers adding different, not all of them, but some of them work for some people. Massage therapy may work. Acupuncture, we actually do have an acupuncturist here at the university who has I believe, an anesthesia doctor. And then electrical stimulation, that would be like a TENS unit where they put the electrical stimulation to a particular area, and that helps. So those will be examples of physical medicine. And then cognitive behavioral interventions. This is mind-body medicine, such as meditation, cognitive abstraction, and reframing, and psychotherapy, and structure support. And again, each one of these may be helpful in some patients and in others. Meditation. There's strong evidence of using relaxation techniques and reducing pain. Various techniques and practices used to induce a certain desired state of mind, results in enhanced physical and emotional well-being. And examples of meditation techniques may be counting breaths or relaxation using visualization and imagery. Then there's cognitive distraction and reframing. Distraction is the strategy of focusing attention on stimuli other than pain. These distractions may be internal or external. So, for example, listening to music may be external distraction. Then there's reframing, which involves monitoring and evaluating negative thoughts and images and trying to replace it with more positive ones. And these are coping mechanisms that we try to institute with the patients, and our health psychology service helps us with instituting some of these coping mechanisms. Then psychotherapy and structure support. As we discussed, pain is emotionally stressing and can increase anxiety and depressed mood. Therefore, opening and talking is helpful. Having somebody to be able to identify stressors that leading to these painful episodes may be beneficial. And like I said, there's a cycle that may be there where there's increased anxiety and depressed mood, which contributes to the pain, and then pain subsequently contributes to anxiety and depression. So by having some intervention here may break that cycle. So therefore, in conclusion, using various classes concurrently has a synergistic and additive effect, therefore multimodal analgesia. This helps to avoid the opiate dominance, therefore reducing the adverse side effects. And you don't just rely on one medication or class of medicine alone. And I believe results in increased patient satisfaction